Okay, we're going to go ahead and get started. Remember that if you have a question during the course that you want to write down, if you raise your hand, we'll send somebody to grab it and bring it up. Okay, so we're going to start with this question. Somebody asked that there was a 60 Minutes episode about ultrasound on the brain. Ultrasound on the brain. Is this being considered at the Fixel Institute? So what this is talking about, when we go beyond medications and what we consider advanced therapies, this is usually when someone has had Parkinson's for a number of years, and the medications relieve the symptoms, but they may have side effects when it kicks in at its peak. And that could be involuntary movement, we call dyskinesia. It could be getting lightheaded or dizzy. And it could be that the medicine wears off too quickly, and they could be taking doses very frequently and having a lot of ups and downs. And so what we call our advanced therapies are things that try to smooth out those ups and downs. You heard a little bit about pump therapies in this room. But also there are surgical or more invasive approaches. And many people in the room have heard about deep brain stimulator surgery, which involves implanting a wire or electrode and using electrical pulses to modify the brain circuits. Before we had DBS, there used to be an approach that was called lesion therapy, where a small hole was burned in the brain, usually by a surgical approach. And we call that an ablation or a lesion. And DBS was an innovation to that. Instead of permanently burning a hole, using electrical pulses to sort of modify how the circuits are firing. And so now we have a new version of the old therapy, which is to make an ablation or a lesion, but instead of opening the skull and going inside to do it, using an ultrasound beam to burn a hole. Some people call this non-invasive because it's not a surgery. And some people would say it's more invasive because it's permanently causing a damage to a small area of tissue. But it's another option that can modify Parkinson's, the symptoms. So you might say, well, why would you pick one or the other? There are some cases where there could be reasons not to have a surgical approach or hardware implanted. Maybe someone is very prone to infection or very frail, or maybe they're on blood thinners and it would be risky to discontinue them for a period of time, or other reasons. Maybe they don't have access to a center that they can get programming done regularly, and they don't want to have repeat surgeries for the battery. The downside of the focused ultrasound is at this point in time, it's only done on one side of the brain, because whatever lesion is made is permanent, and you could have side effects like balance trouble or talking trouble that are too risky to do both sides at the current state, in the current state of affairs. Maybe this will evolve. Also in the state of Florida, it's not yet covered by insurance. But the answer is that yes, we are beginning to do focused ultrasound at the Fixel Institute. Our neurosurgeon, Dr. Hilliard, is beginning to do them for cases of essential tremor, which is a different kind of tremor than Parkinson's. And we'll eventually be planning to do that as well. And so when people consider advanced therapies, we would tell them about both approaches and the pros and cons, and they would decide about that.
Sure. My name's Alana. I'm the social worker for those who have not met me. So the question was about, is there a nursing unit that can accept Parkinson's disease patients? Right now, we don't have that in our area. There is some training that is in progress for the hospitals. Would you like to say anything about that?
Yeah, so whoever was in this room after Dr. Carpentier's talk might have heard that we're doing a big initiative to improve hospital safety in Parkinson's. So Dr. Carpentier and I and others, we've involved nurses, the medical record computer people, the pharmacy people, the rehab team, the doctors, and the nurses, everyone who is immediately hands-on with getting people their medicine. And all those different departments are meeting. We're having meetings to try to figure out how we can improve safety. How can we make it possible for the nurses to give the medicine on time when they have a lot of patients to take care of? How can we make sure that doctors who don't know about Parkinson's at least don't give the medicines that we know worsen Parkinson's. And so there's training going on, and all of the nurses in our hospital are going to be taking that. But many of you might not live right here in Gainesville, and you might get care elsewhere. And so if you are going somewhere that doesn't have specific Parkinson training, which is like 95% of the hospitals, you can take advantage of the Parkinson Foundation Aware and Care campaign, which has printouts you can print off the internet or ask one of us to print for you that lists medicines that are not safe in Parkinson's and safe alternatives they can give you instead. And it also says, I have Parkinson's, I need my medicine on time, every time, and some suggestions. So that can help. Okay. All right, Dr. Chan.
Sure. So the next question here is, this week a local channel said that a diabetes drug was being successfully used to slow progression of PD. Do you know which drug they are talking about and which stage this trial is at? So that study was briefly mentioned by me during the presentation. So the drug is lisenatide, and that was a phase 2 study. So a bit more detail about it. So essentially they looked at 78 people who got the drug and 78 people who did not get the drug, so they got placebo. And essentially, by the end of that trial, right, so by 14 weeks after the study began and these people took the medication for 12 months and 2 months after that, right, they found that the group that got the drug had a slight improvement or slight, I guess, better motor scores compared to the placebo group. But if you look at the numbers, it was a 5-point difference in the mean UPDRS. That's the motor exam score that we get everyone to do during the visits. So really, when you look at the numbers, it's not a big difference. So there's some promise, right, to say that these diabetes drugs may have some benefit for Parkinson's, but that benefit in the short term and the long term is not entirely clear at this point. So again, that was a phase 2 trial, and there's multiple studies being done right now using different specific drugs in that same class of GLP-1 agonists to learn more about how that's going to play out. Now, of course, like we mentioned earlier, these diabetes drugs, these GLP-1 agonists, are widespread in terms of their use for diabetes and weight management. So these medications are already out there, and there may be some in this room, right, and definitely people who around the world are on these medications for diabetes or weight control, but it's not clear whether those medications are providing Parkinson's benefit. Right, so at this point, that was a phase 2 study, very new, but we do need more studies to better understand how these medications are truly going to work from a Parkinson's point of view.
And also to mention that weight loss is not always desirable in Parkinson's. It often happens unprovoked, and we usually have concerns about maintaining body mass, and also it can cause slowing of the digestive system, which can be a problem in Parkinson's. So we have to really see if there's an actual benefit that's worth some of the risks of that.
Just wanted to say something else about this, is that there was another big study. I'm Adolfo Ramirez, I'm one of the neurologists here at Fixel. We were part of a different study, a different initiative, looking at exenatide extended release form. And in that study, it was published maybe a few months ago, what the results indicated that a group of people with the younger patients actually did better. The study was overall negative, but there was a trend that people 65 and younger that received the drug, that the effect of the drug slowing down progression was more noticeable. So a lot of different questions. We don't know why someone younger would benefit from it. All these patients with Parkinson's, we know, are very different from each other. So a lot of really important learning points with all these studies. More to come, but it seems encouraging.
Okay, I'm Ariane Carpenter. I'm a movement disorder fellow. And the question I got is, I'm a Fixel patient with Parkinson's disease. Can I get my record set up with the alerts about medication timing if I'm hospitalized? And what about contraindication medication that I shouldn't be given if I'm hospitalized? So that's an excellent question. We're not there yet, okay? So hopefully we're working with the electronic medical records guys and girls to work on that and find solutions and alerts when you put a foot in the hospital, it says, you know, that the patient that just got admitted has Parkinson's. It's super important not to give this medication. It's super important to give medication on time. But I don't think we're there yet or close from being there yet. So I think all the precautions we discussed, again, printing that information from the Parkinson's Foundation website, make sure you have it with you all the time, is crucial, not only because we're not there yet at the Fixel, but you can always be on vacation when it happens, you can be not in Gainesville when it happens, and so making sure that everyone knows about it, and even us at UF, we're not there yet. For the contraindicated medication, I think we had a tip from a patient here. You can always ask to put these medications as allergies in your chart. And so you're going to make sure that these medications are never given to you. And I think that's a great tip. You can do that at UF. You can do that in other centers. So when you meet with our nurse before the appointment, you can ask them to add those medications to your allergies, or if you have access to your MyChart online portal, you can do it by yourself. So.
I also want to mention that the Parkinson Foundation has made some national recommendations for this, that they just wrote a paper about this to communicate to the healthcare community the importance. And Dr. Carpentier is in the middle of a draft of a paper reviewing all the known literature about what is dangerous in Parkinson's, about the risks of falling, the risk of swallowing aspiration that causes pneumonia. And so there's a lot of work going on to try to get the message out there, and hopefully that will get better in the future. Dr. Ramirez, you want to take a question?
Yes, I'll take the next one. This is a question about symptoms of Parkinson's. The first question is, why does speech get softer and quieter over time in Parkinson's? And why does the handwriting get smaller and almost illegible as time goes on? And these are really, really good questions. And one thing that we have learned about Parkinson's is that the patients with Parkinson's have some trouble in the part of the brain that's important for perception. And speech is probably the best example of this. Patients feel that they're speaking at a normal volume. They just almost don't realize that they are not. Because for them, the enunciation, the power, the volume of the voice feels right. There's a mismatch between the voice as it's being generated and what the patient is perceiving. So that's why therapies like big and loud or speech therapy, LSVT, can really help to change that, because then you learn how to use your respiratory muscles, how to project your voice much better. And then with habit and practice, you can modulate some of that perceptual problem. The other thing that is very common in Parkinson's is that we know that when you have reduction in dopamine, there is a failure there's a failure to energize the muscles quickly. And especially with tasks that are very complex, like handwriting, what happens is that you can start and the handwriting may look pretty good, but then there's a failure of those muscles to energize quickly and to coordinate in a precise manner. And that's why the handwriting gets really sloppy over time. Perception problems and problems with fine control of muscle contractions and coordination are common in Parkinson's, and they account for some of these issues.
Thank you.
Hi, Dr. McFarland. So I've got a question from somebody who asked about the stages of Parkinson's disease and how we define them and sort of what do we use. And I'll just preface this that yes, we do have a lot of scales and research technique, research tools that we actually use in our clinic and our practice, and they do use stages, but those stages are actually somewhat artificial. They're things that we have defined, so they're little boxes that we put patients in. Some of the scales actually that we use to evaluate you, like your exams in the clinic, actually are they're basically spot checks, okay? You could be doing really well at the time that we examine you, and you might be in what we call a Honeyard stage 2, meaning you have sort of bilateral symptoms. So that's not really a stage, it's really kind of like a research stage or criteria that we use to evaluate you at the time. You might be in an off state, and you actually might be stage 4 in that particular scale. But that is a research scale, and it's an exam scale, okay? I think what this question really gets at, or maybe the root of the question really gets at, are actual disease states or scales that you guys would be interested from a clinical perspective. And I'll just say that there really isn't one particular staging system that any of us really uses clinically for patients overall. I think we can't put people in a box like you're stage 1, 2, 3, 4, 5 of your disease necessarily. You may read about these things, but no one really, everyone kind of disease progresses in a gradual way, okay? It's not like one day you're in stage 1 and day 2 you're in stage 2, okay? That just doesn't happen, okay? So by and large, we kind of talk to you all in terms of, are you in a mild or early stage of Parkinson's, or we call a moderate stage of Parkinson's, or more severe. So, when I think about someone who has mild Parkinson's, that's early stage Parkinson's, where treatments, or most treatments, actually just work. And for me, that's sort of a honeymoon period. One of the most common treatments we use is levodopa, and I think if you've had early Parkinson's, when we started you on your levodopa, it just worked, okay? For most patients, it works really great, okay? And there were no you probably didn't recognize what were called on and off type symptoms. What that means is you didn't realize whether the medicine was just working for you or it stopped working for you for a period. It just worked all day long, and it worked great. It didn't matter really when you took it necessarily. So that's kind of like an early stage of Parkinson's. A more moderate stage is when people start having what we call fluctuations. It's when you start to begin to notice that the medication may not last quite as long, and you may recognize those periods of time where when it doesn't work, you're in that we call off state, and that's kind of what Michael J. Fox calls like being off the bus versus on the bus when the medicine kind of works for you. And those sort of off and on states can fluctuate throughout the day depending on when you take your medications and how you respond to it. So people who fluctuate or have those ups and downs throughout in their disease, and it just kind of varies from whether that's a mild thing or it's a more severe thing. Sometimes those fluctuations can be almost random. People can have sudden periods where they're really off, where they can't walk, they can't talk. They may be frozen. For instance, they might be walking in the grocery store and suddenly they can't walk at all and they're stuck and they need their wheelchair. They need to be taken back to the car. That's an sudden off state, okay? And those fluctuations, that sort of spells out a more moderate stage of disease for us where we have to kind of modulate your medications. And it may require other medications and things. In addition, during those periods of time, we might even discuss things that are non-pill. They might be those surgical options that we start to discuss in Parkinson's disease. A more severe state of Parkinson's disease are where there are other symptoms that cause complications, more non-motor symptoms. And I'll give you some examples, things like systemic, things like fluctuations in blood pressure, a lot of issues with GI, the gastrointestinal tract, dementia in particular. When that starts, it really adds another dimension to the disease of Parkinson's disease. And as you can all imagine, when dementia really occurs, additional care is often necessary. And it does sort of spell a different rate of decline when someone develops dementia. And if on top of that, there are episodes of hallucinations or behavioral issues, that adds another dimension on top of things. And that so it just becomes a much more complicated disease, okay? The duration of disease also plays a role as well. So it's a complicated question, and I think it's something that's individualized for every patient, and I think it's something you should talk to your neurologist about and ask, sort of, where do you think I am along my journey in Parkinson's disease? Am I at the early stage, sort of a middle stage, or more late stage? And to begin to have those conversations. And so where you're at the moderate stage, I think you need to start thinking and talking with your loved ones about kind of what kind of care things, how would you like to be cared for? It's also, my experience is really good to even think about those that are at the earliest stage, really. What are your life goals? How do you see yourself with your Parkinson's? What are things that are important for you, okay? I know Parkinson's disease is a long duration illness. We talk about 15 to 30 years or even more for some individuals for having this disease. But there are some individuals who have a more sort of rapid progression. There's we call a malignant form of the disease where patients do progress a lot more rapidly and tend to be sometimes older, but can be younger too, okay? So again, If you can, I think as a recommendation from a physician, even at early stages, and you're asking if you're getting a new diagnosis of Parkinson's, start to think about these things about your Parkinson's disease and ask questions. But along the line, you may end up having different questions about where am I, and have those conversations with your neurologist and discuss kind of your care goals and what's important to you, okay, along the stages, okay? Hope that answered your questions.
This is a question about travel, and so as I'm going to just give a patient and family response, and then I'm sure some of the physicians here will offer more expertise. But the question was, what suggestions do you have to help with travel stressors, whether the travel is by car, plane, or cruise ship? I would just say, again, I'm very fortunate to still be doing so well. I seem to be in kind of a perpetual honeymoon stage with Cinemat's effect on me. But I think you have to I guess what I would say is you just have to really pay attention. I got up at 3 o'clock in the morning yesterday to fly here from the West Coast. And I'd thought about that in advance, that I would go ahead and take my medication at 3:30 in the morning, which I normally don't do, but morning is my toughest time. And I thought, well, I'm flying to the East Coast. I'm going to take that now because that's really 6:30 East Coast, which is when I would normally take it. And so I think staying to your schedule and being conscious of that. I'm sure, like many of you, I have my pill alerts on my phone, and I religiously pay attention to that. So I think staying with some of those things is really important. I'd also say that I think traveling while you can and as you can is really important because it's part of what allows you to stay engaged in the world. I think just making accommodations, thinking about it, because the stressors that can happen in travel are in part just because they're different. So thinking about, okay, where am I going to stay? Will there be steps? I have to think about whether there's an elevator, all those kinds of things, which are sort of obvious, but to really think and plan ahead on can make a real difference. The other thing I'd say is that travel can change, I think, as you age. I talked a little bit about this morning about the great pleasure my mom took in going to Stanford sporting events. That was her travel, And that was still really possible. We actually got great seating because we sat in the handicap accessible seats. Got better seats that way than any other time. So I think thinking about travel in a slightly different way can also be helpful. And then finally, I guess I would say that there probably will come a time when travel isn't possible. I accompanied my parents during my dad's last years on a trip my mom really wanted to take to New England to see the fall colors. And, it probably wasn't a great idea in some ways for my dad. But I could go, and I think that's something then to think about. Can someone else come with me? Can a younger family member come with me? Because it turned out that was really a special experience for me to be able to spend that time with my folks. And I remember one evening at a hotel where we stayed at, my mom liked to dance, and so there was dancing. And she just turned to me and said, will you dance with me? And because my dad couldn't. And I did, and it's a really sweet memory. So I think the ways in which you can engage with travel will change over time, but I think engaging as you can is still really important.
That is such beautiful advice. I'm so grateful that you shared that. And I'd like to add just a few practical tips. One of them is always keep your pills in your carry-on luggage. Never put your pills in your checked luggage. I did this stupid mistake once in our family, and it's not even a Parkinson's situation, but it's when your suitcase is lost, that could be very stressful. Also, I recommend
take extra medication.
Take extra medication.
I always travel with, I'm just here for a day, but I brought 4 days worth, because you never know.
So smart.
So having that and having that accessible, I carry my pills on my keychain. All of that's really useful.
This is a great idea. You never know if you're going to miss a flight, delay a flight. Also, I recommend in general having a keychain. They make keychains with a little compartment that you can keep a few pills on you always. There we go. That's exactly what I had in mind. So useful. Secondly, I want to add, if you travel by air, it is a service that's available to you to say, could you please transport me to my gate? They can put you on a cart and drive you there. Now, for some people, it may be obvious they need that assistance. Someone in this room or elsewhere may not look so bad, and you might think, oh, they're going to think I'm just lazy because I don't look like I have Parkinson's. But we all know that when you may be able to do the travel, but maybe you're so exhausted then that you don't enjoy what you're traveling to go see. So you can conserve your energy and ask for transportation to your gate. Also, time zone travel, you heard about that. If you're going to travel across time zones, just talk to your doctor, what should I do? Usually we'll tell you to take an extra dose if you need it when you're extending the duration of your day, when you're traveling in that direction. But I'm so happy someone asked that question.
Let me make one more comment. I just want to say one last thing, or one other thing. For travel, I would just think about, so the term I would use is flexibility, okay? And I think as we grow older, and then with Parkinson's disease, the flexibility and ability to kind of change, go with the punches, becomes it's less and less over time. So think about kind of the stresses that you may encounter, and changes in sort of both times, spaces, particularly if there is sort of memory or thinking issues. Waking up in a different hotel can really set someone back and can cause significant confusion and agitation, and it can cause problems. And also think about time and how far can you travel. So kind of the recommendation I really say is you may think about, oh yeah, I used to be able to drive all night long or drive, for a really long period when you're traveling. That may not be the case anymore. So shorter travel times, build an extra time when you're traveling. Just think about that flexibility and what can you handle, and be prepared for those additional stressors when traveling. And I do love this recommendation about sticking to schedules. It's, when you're traveling, schedules kind of go out the window, and it really can throw you for a loop.
Can I also just add to sticking to schedule? I would include exercise as part of that. I walked in the airport, back and forth to get in some of my miles that I stick to each week. When I got here to Gainesville, the first thing I did was go for a walk. So for me at least, and I'm lucky to be in that position, sticking to that part of it, not just the pill regimen, but if you have an exercise regimen, I think it really makes a difference with travel too. Sorry.
I just really quickly wanted to say, if you have a neurostimulator, a DBS system, you may want to take a little extra time. And I always tell patients, please plan, at least for me, one of the biggest stressors, even if you have TSA pre-check, is just to go to Orlando Airport, and then you walk in there, and there's like a 3-hour wait just to get through security. So take an extra time, and if you have a system, like a DBS system, you want to ask for a pat-down instead of going through the machine. That could really delay. They can call the supervisor, and I've heard a few crazy stories where it took a long time to go through security because the officers just didn't know what it was. So plan for that, plan for a pat down, and then take extra time when you get to the security gate.
Okay, so we always nicely have more questions than really a lot of time, so we'll do a bonus round where we'll try to answer as many as we can, as efficiently as we can. So I'm combining these two questions. One of them is, I take carbidopa, levodopa 4 times a day. The person has their schedule. But many times the drug wears off before my next one. What causes variation when that wears off? So why sometimes it may last 4 hours, sometimes it may only last 2 hours. And so the tricky thing is, as you have Parkinson's longer, the changes in your brain are different. So what used to work doesn't work in the future, and you may have good days and bad days that are unpredictable. There are a few predictable things, which are when you're stressed or when you're exhausted, or if you're sleep deprived, that can make your medicine seem to work less effectively. And your dietary fluctuations can make your medicine work less effectively. So if you take your medicine with a very high protein load, you will absorb less of that dose, and you might feel like that dose didn't work. So sometimes taking your medicine 30 minutes before you eat or 2 hours after you eat, if you can make a schedule with your healthcare team, it can help you avoid food and medicine interactions. Similarly, someone said, why don't we have a nutritionist or dietitian help make a flow chart with food? And we actually have one on our team. We recognize it's that important. At the Fixel, we actually have a dietitian on our team, and sure enough, sometimes he has to sit down and say, okay, let's figure out what time you wake up, when do you go to bed, when do you like to eat, and how can we make adjustments to try to avoid that? So that can be an important thing.
All right, the next question is, can a vibrating glove treatment relieve Parkinson's symptoms? So this is a big headline in 2023. It made the news cycle pretty much everywhere, where I think a group in Stanford came up with a glove that you could wear, and it miraculously stopped tremors, made you move better. And so, of course, everyone was asking about, can this glove actually treat Parkinson's? And as we found out kind of more and more over time, the short answer is not really. But it's a bit more nuanced than that, right? So it was a study glove that was in a very select population of people. And so when they presented the results of that study, it looked very great. It was very great, right? But in practice, we just don't know enough about this therapy in a broader population. The theory behind it is perhaps, a vibrating sensation gives feedback to the hand or the arm or whatever body part, and that feedback of the sensation causes your brain to reinterpret how you move, and so it then settles down the movements. And so in theory, that's what's supposed to happen, but we really don't have enough information as to whether that truly works or not. And I think if you look more broadly, and I don't necessarily recommend trying this for yourself because it does cost money, but if you put a vibrating glove in your hand, chances are it won't do a whole lot.
The question I have is about specifically Bliss Bite CBD gummies advanced formula for Parkinson's disease. And so I just look it up because I don't know specifically that CBD gummies brand, and I'll take it as a broader, like, can CBD help Parkinson's disease? And so basically there's no evidence that CBD, which is one of the products of marijuana, there's THC and CBD, that it helps. Potentially some people that have anxiety or sleep issues can benefit from it. Is it placebo? Is it a real effect? But I would really be careful. If you buy it at a vitamin shop, and it's not like a marijuana dispensary, usually it's only CBD, so it's usually relatively safe, but we never know when you put something extra in your body, will you have some sort of reaction. But CBD is usually well tolerated, but really doesn't help, and it costs money. So if you try it, you have somewhat of a good response, even if it's placebo, and we love placebo, you can continue if it's financially viable. But otherwise, we really have no evidence, and I wouldn't touch THC because it can cause confusion and side effects in Parkinson's and pretty much anyone. So I would stay definitely away from anything that contains THC.
Great. Quick question here for us. Can you speculate about when the FDA will approve the AbbVie subcutaneous pump, and when can we expect to have it here? The pump has been approved in Europe in the past couple months, and last month was approved in Canada. So the data was submitted to the FDA, I believe, at the third quarter of last year, and safety and efficacy has been shown. They wanted to get additional information about the pump itself, and the tentative time for release would be in the second half of this year, probably closer to the end of the year. We will know a little bit more in a few weeks. Most of us are going to the American Academy of Neurology meeting that's taking place in Denver in about a week. So we'll hear a little more about it, maybe an update. But I would speculate that probably by the end of the year, closer to the end of the year, we should be able to start thinking about how to offer these therapies.
All right. So someone asked about a blood test for Parkinson's disease, specifically for alpha-synuclein. So first I'll just start with what's alpha-synuclein. That is a protein, it's a normal protein in your brain that goes rogue, and it gets accumulated in what are called Lewy bodies. So Parkinson's disease is one of those Lewy body diseases. You can only see these under the microscope. You can't detect these on a brain scan or anything like that at all. So someone may have heard recently that Michael J. Fox, and actually there's been multiple studies that have kind of built up to this, but they announced results of the Parkinson's Progression Marker Initiative, the PPMI study, that we have a new test that detects alpha-synuclein in the spinal fluid, okay? So how do you get spinal fluid? You need to have a lumbar puncture, or what's called a spinal tap. How many people want to have a spinal tap? It's an easy procedure, but no one really wants that activated. So that's a procedure that takes time, and it's not a simple procedure just to do in most offices. So it'd be really ideal to have something else where we could detect this protein. And ideally, a blood test would be really easy, okay? There have been a lot of challenges to get there, okay? I think one thing first, really, whenever you look for a marker of disease, we call those biomarkers, you want the marker to be specific as well as sensitive, okay? Sensitive just means like can detect something. Specific means is it specific to disease like Parkinson's. So it could be a marker, but it might not be specific to Parkinson's, you know? It might just mean, like if you lost your sense of smell, that's a risk factor for Parkinson's disease, but it is not specific, okay? Because there are many other diseases where people lose sense of smell. So you want a sensitive and specific marker. Alpha-synuclein is sort of that. In blood, the problem really is that alpha-synuclein is actually a protein in blood cells, okay? So there's a lot of noise there, okay? So it's been really challenging to create a specific test to measure brain-derived synuclein in blood. So there's huge amounts of challenges. Are we up to it? Gosh, yes. So there are hundreds of researchers across the world who are actually working on this problem. There's active research ongoing. I can tell, if you want to know, feel free to ask me. There's a lot of research going on, even stuff in the United States, to find ways to selectively kind of pull out the synuclein that we think comes from the brain that might indicate a disease like Parkinson's disease. So it's just, I think, a matter of time. I'm completely optimistic that we're going to be able to do this. I do believe these markers for disease are a sea change. The fact that we can measure this in spinal fluid and maybe even show some differences between Parkinson's disorders is huge. It's a sea change. So not only, you know, we all kind of diagnose Parkinson's clinically. We're darn good at it, I think, you know, up to 90%, but we're not 100%. Having a pathological marker for Parkinson's disease, some way to detect it like in blood, would be huge, I think, for all of you, and particularly a way to detect it early on. If we're ever going to have ways to target this disease early on, we want to stop it early on, ideally even before it starts. But how can we tell if you have Parkinson's early on? Those symptoms are often subtle when you begin. And how do we know who's going to get it and who's at risk? So having this marker, we call a biomarker, is critical. So lots and lots of people are working on this, and I am really optimistic that we will have it. It's just a matter of time, okay?
Thank you. I also want to just take a minute to thank Dave Wright from North Central Baptist Church that helps us every year and donates his time helping Chuck with the AV. I would love to give him a round of applause. This has been super kind and helpful. And our young volunteers, Dr. Ramirez's children, Carolina and Olivia, and mine, Alexandra and Sophia, for helping us run things around. Susie, Shafina, Alana, all of you, so grateful. So just a few final questions before they really kick us out and pull the plugs on our microphones. This one is, this is an important question. What general advice can we give about these day-to-day activities and easing discomfort and melancholy in someone and their quality of life who really is not a candidate to participate in all of these beautiful programs? What if you have more severe Parkinson's and you can't make it to art and boxing and dance and all these really wonderful things? How do you help that person? And this is a beautiful question. First of all, in Parkinson's, apathy is a common problem. What is apathy? Apathy is a loss of drive or motivation. This can happen at any stage of the game, advanced or early Parkinson's, where a person just, it's harder to find motivation to do stuff. And they might know what would be good for them. And all of us, to some degree, have to fight, you know, lack of motivation certain days. But it's part of Parkinson's, the condition itself, even in people who aren't depressed. So how do I help someone who doesn't maybe even have drive, or maybe they physically can't get to those things, or they live somewhere that those things aren't available? First of all, there are programs online through the Parkinson Foundation, or when you come see us at our center, we can show you a lot of websites where you can have virtual, meaning watch on the computer, exercise programs, talks, support groups. Attending support groups can be helpful for people with Parkinson's and people who love people with Parkinson's. There are even exercises you can do in a chair, sometimes just any movement. You can hold a can of soup or a bottle of water or nothing and do exercises that keep your flexibility or movement. I think it was a beautiful point that was brought up about when you have a subtractive condition or anything that takes away from your quality of life, you have to deliberately add things that improve it. If you can't add exercise and movement, maybe you enjoy music. Maybe you enjoy visiting with people. Maybe it's your spiritual community. Do the things that give you joy and community and activate your brain and body as much as you can. And I'll mention palliative care services or services besides just trying to fix things and modify things and do procedures. Palliative care is in the advanced stages of a condition that there's not a cure for yet. It involves improving quality of life, and that means figuring out what's important to a person and focusing on that. So trying to relieve suffering, if there's a symptom like drooling or pain, talk to the doctor. We may have treatments that can improve those things. So it may not be the programs we listed. There may be other ways to get fresh air, get movement, and improve quality of life. Last couple questions.
Sure. So I have two questions here. So the first is, are the therapists at Fixel considered to be neurotherapists? The short answer is yes. So physical therapists, occupational therapists, and speech therapists who have extra training or experience in neurological conditions are considered neurotherapists. And specifically, really like ours are also movement disorders therapists as well. The second question is, how many bodily and mental functions are dependent on dopamine? So this is a great question because it really gets at the core of what Parkinson's disease is. And for many of us, we look at Parkinson's disease as a movement disorder, and the thing is, movement is the obvious symptom, because if you're not moving well, you know that, or someone else can see that. But dopamine and Parkinson's, it's a whole brain disorder, so it affects every part of the brain, and so everything that the brain does can be affected. In terms of perception, we heard a bit already, it can affect perception, it affects cognition, so people with Parkinson's often feel that it's harder to concentrate or stay focused, and it's harder to remember things in the short term. It can affect your mood, it can affect this apathy that Dr. Milani just talked about, right? And there's a lot of stuff that our bodies and our brains do that we don't think about, and those are the automatic, autonomic functions, right? But that's why we always check for things like, do you get lightheaded when you stand up too quickly? Are you constipated? Does your bladder work properly? Is there sexual dysfunction? So really, dopamine is doing a whole lot, not necessarily by itself, but also with other chemicals in the brain and so on, but really it's a whole brain, whole body disorder.
Adolfo, Nick, did you have one or two left? Or?
Oh, I'll use this one. Yeah, there are a couple of questions, couple of final questions here. One question is about Parkinson's disease and the genetics of Parkinson's. Parkinson's genetics are complex, and for the longest time, we didn't think that Parkinson's had any genetic component. The first genetic mutation ever discovered in Parkinson's took place in 1997, so not that long ago when you think about it. And the early cases with genetic forms of Parkinson's were very rare, like a handful of families here and there. And as we are learning more and more about what causes Parkinson's and all the different things that can contribute to Parkinson's, we now know that about 10 to 15% of all the cases in Parkinson's are related to a genetic mutation. It's more likely that you have one of those if you are younger when you are diagnosed with Parkinson's. So the risk of having a genetic condition or a genetic mutation is much higher if you have Parkinson's at an early age. Now, a common question is like, well, what is the risk of my family members if you have one person in your family with Parkinson's? What's the risk for my kids? What's the risk in general? So overall, we think that that risk is very small. It's just slightly increased from the risk of all of us. As we get older, the most powerful risk factor for Parkinson's disease is age. As we age, our risk goes higher, gets around 2% if we live to be around 80. So the risk is slightly higher in someone that has a first-degree relative, but it's not that much higher, maybe about 5%. And then that risk kind of levels off if that person lives to be 80 or 70. So again, age is the main risk factor. If you have a lot of people in your family with Parkinson's disease, then the risk is a little bit different. And that's what I meant when I said that the genetics get really complex, because some of these genes are risk factors for Parkinson's, and other things needs to happen during your life to trigger the chain of events that cause Parkinson's disease. We still think of Parkinson's as being a disorder that's a combination of exposures through our life, getting older, and a genetic predisposition.
Could I just add one thing? I just wanted to add to these really important questions that have come up that you were discussing about Parkinson's going beyond just the movement issues, because I think many of us contend with those things, and it's just really, I just want to encourage everyone to talk to your movement disorder specialists about them. I have problems sometimes with low blood pressure and getting dizzy. It was really helpful to talk to my movement disorder specialist about that. Same with bladder and bowel issues. But the other one I want to mention that has been mentioned briefly is things that are more about how we're feeling emotionally. And there are, as I understand it, medications that can be helpful in that regard, that are okay for people with Parkinson's to take, antidepressants. I have never been a terribly anxious guy. I became one. and I talked to my movement disorder specialist about that, and he prescribed a very low-level anti-anxiety medication. That's been really helpful to me. So I just think it's important to recognize all those other aspects of Parkinson's that can affect our lives, and to have a trusting relationship with your movement disorder specialist so you really can talk about anything. And you have wonderful ones here at the Fixel Institute. I just really encourage those kinds of conversations.
I'll just finish. I'm so glad you mentioned that. I'll just second it, and I'm sure we all will second that. Please talk to us about Parkinson's is so much more than just tremors and shuffling gait, speech issues. More than half of the things are we call non-motor, so talk to us about them. I'll just finish up really quick. I have a couple more, but they're going to be really quick, okay? Someone asked me about antibody therapy. How does it get across the blood-brain barrier? I'll just be really quick. So antibody therapy is targeting proteins like the alpha-synuclein things. It's really difficult, okay? The blood-brain barrier it's not an open thing. It's not supposed to be. It's supposed to protect your brain. So even if we give it sort of in the blood, a very, very, very tiny amount actually crosses into the blood-brain barrier. So that's one of the major challenges. Same thing for a vaccine, okay? Crossing the blood barrier is really hard. So we don't generally do these therapies by injecting inside the brain or anything like that, but it is a major challenge for researchers to figure out how to do that. So we're looking at sort of delivery methods that, we put it in the brain, or other ways to, provide what are called sort of immune type therapies for Parkinson's disease. And then someone asked about other growth factors and angiogenesis therapies, and I'll just be really short and just say that's very, very much research, and we're still looking at that in animal and some human studies. I don't have an answer for you yet, so stay tuned, maybe next year.
Thank you so much, all the panelists, everyone that's here. Amanda Facenda did an amazing job, like every year, creating this for us. Susie Sharp next to her, and the Parkinson Foundation for partnering with us. I want to just part by saying we actually have several support groups for people who would like to learn more on an ongoing way throughout the year. We have a general support group, and people who have Parkinson's or know someone who does are all welcome. There also, recently, we have a women's group that will be meeting for people who would like to meet just women, and a Black Parkinson support group that's being started. So sometimes we all share certain things, but sometimes our unique experiences bear connecting over. So Amanda here or I would be happy to connect you with the support groups, and thank you so much for coming.